Hi everyone, and welcome to Anaesthesia Coffee Break. I'm Lahiru.
And I'm Stan.
And today's we've got a really great episode because we're having a bit of a celebration today. And also we're talking about the differences in arterial and end-tidal CO2. So let's get started. Okay, so welcome. The obvious disclaimer, everything that we talk about is just general stuff for education purposes, and it is not complete medical advice. So please, if you're treating a patient, trust your treating team and consult with a specialist for that reason. So, Stan, we're celebrating, aren't we?
We are, and apologies if my voice sounds a bit hoarse. I have been celebrating last night, albeit socially distant while we're still in Melbourne. We've had some great news. So all our Northwest trainees passed their exam. So very happy. And yeah, you should have, do you have the little button where you press where you get like a mass audience that claps?
Yeah, I'll edit that fake audience in.
That should be our next stage of video production. But the most part that I'm sort of proud about is as a team, so as the team at Western Health and also Austin, Royal Melbourne, Northern as well, and Peter Mac, and also the country hospitals as well, Ballarat. So hopefully I haven't forgotten any other, and Albury Wodonga. So as part of that whole consortium, what I should be most proud about is that we had trainees who were sitting for the second time, and we managed to get all of them through. And so that was a massive achievement. So I'm so ecstatic for everyone. I'm so happy for all the individuals. And I know talking to a lot of them that they listen to the podcast as well. So I'm sure they'll be thanking you as well, La, for all your assistance and guidance with this exam.
And I got to say, just, so much applause for you because I don't know, I feel like you've just done so much work. You're doing so much work in this, and you've mobilized all the resources around us. The way you get people to, you ask them to do and support and train, and then you lead from the front. The amount of time you spend on this to try to get people through this. I mean, this is the hardest thing that most people will have done in their whole lives. And, especially if you failed it once, it just feels so good. I can imagine if I was these trainees, maybe they've failed a couple of times, and to get through,
it's a massive feeling. Yeah, well, thanks, La. Look, I do have to say, I do get emotionally invested in the process. And so the joy that it brings is immense and priceless. And I think that, in terms of a performance tip for today, it's celebration. That's my performance tip, as in you celebrate the good times. So you have all these trials and tribulations and all the things that you the steps that you put in place to deliver success. And when that success happens, I think celebrate it. And it's a cause for a momentous occasion for everyone to get together and just reflect on how we as a team can produce such positive memories and such positive change in our community.
And I was recently talking to a friend of mine, and she was a massive influence in my life over the past kind of two decades, and she's going through a really tough time. And in her, in what she's feeling now, which is really bad, she couldn't appreciate how much of a difference she's made in so many lives. And literally, I was just telling her that she's kind of defined my life for a couple of decades with all the stuff that she's done with me and my team, and she doesn't remember that. She doesn't remember the good stuff. It's just that we're in lockdown and her business is struggling, and it's a whole new world for this poor person. And I told her that one of the greatest joys is looking at the projects that we did and completed, and that makes me feel happy. And I think just telling her that made her happy, because I think she forgot that she's very important to so many people. And I was thinking, now is the day where data is so accessible. Just look at old photos, look at the your previous triumphs, celebrate them a second time. Why not? Life is short.
Absolutely, especially in this in these difficult times. I think you look at the positive things that you've achieved, and also I think you also look forward as well and know that what positive things you can also affect as well. And I think having that mindset allows you to move forward and allows you to create change. So good stuff, La.
Yeah, excellent. So let's get started with some short answer question fun. So,
all right. Yeah. So you're going to talk about a question that's been asked, looks like a couple of times in the past. And the premise of the question is they want you to describe the potential causes of a difference between end tidal and arterial partial pressure of carbon dioxide. And there's a couple of iterations in terms of how it's asked, but that's the genesis of this question. Mm-hmm. So a couple of things I think that are important for the questions are definitions. So what definitions do you have that you think are important to be adding to this question?
Yeah, so when I look at that question, obviously they mention end tidal CO2 and they mention partial pressure of arterial CO2. So those are two obvious definitions. But also, I guess I'm going to invoke the Bohr equation. So maybe even talking about mixed expired CO2 at this time is also pretty useful. And so literally definitions, end tidal, mixed expired, and arterial PaCO2. Now let's talk about each of those. So end tidal CO2, essentially, this is the CO2 measurement at the end of a tidal volume breath, and that represents alveolar gas. So it doesn't reflect any of the dead space gas because literally it's whatever the maximum concentration is measured by your analyzer at the end of your respiration. And usually, this is around 2 to 5 millimeters mercury lower than your PaCO2 and is measured from a capnograph trace. Then you've got the mixed expired, and this is a bit complicated because you don't want to confuse this with end tidal. Mixed expired is, imagine someone breathing out all of their gas from ventilation, from just regular ventilation. What is the CO2 concentration in that? So they talk about using a mixed expired bag or a Douglas bag and take over a period of time, you just exhale all of the volume of your ventilation into that, and then you take a measurement. So that will actually be from all of your alveoli, your normally perfused ventilated alveoli, as well as your ventilated and not perfused or dead space alveoli. So you've got those two measurements, and that's obviously going to be lower CO2 concentration than your end tidal CO2. And then the final measurement, which is arterial PaCO2, and this is around 40 millimeters mercury. And this will essentially very rapidly equilibrate with your alveolar capital A CO2. And that's measured from an arterial blood gas machine. Now we can go into the fact that because we're trying to equate alveolar PaCO2 with arterial, that's called the Enkhoff modification, and that really applies to the Bohr equation. I might even go into the fact that your alveolar CO2 is a function of proportional to the amount of CO2 that's produced, and indirectly proportional to the amount of CO2 that's ventilated. So you've got this kind of balance between production and elimination.
Yeah, that's really good. So, just to summarize, in terms of what you said, the end tidal CO2 represents your alveolar gas. Your mixed expired CO2 includes your alveolar gas plus physiological dead space. And then the arterial CO2 is a function of both the alveolar ventilation as well as tissue metabolism as well, or the production of CO2.
Yeah, exactly. And when I think about that, it's tissue metabolism. Really, what's your metabolic rate? If it's low, you're going to have lower production. If it's high, like in malignant hypothermia is a typical example, but septic cases, hypermetabolic cases, hypothyroidism, then your tissue metabolism goes up, increases your CO2 production. So there's more CO2 in your body through cellular respiration, metabolism. And then really the opposite of that, or the elimination of that, is through alveolar ventilation. And this is pretty much, if you're a normal person breathing, that's your minute ventilation or minute alveolar ventilation. And then through anesthetic circuit, it's really elimination of it. So are you having enough alveolar ventilation that you've dialed up on your ventilator, plus do you have enough fresh gas flows if you're using a Mapleson circuit? Actually, on this point, this was really interesting, right? So if you have a closed circuit system, with the usual soda lime and kind of the general anesthetic system that we use, literally, you can approximate alveolar minute ventilation to somewhere around your minute ventilation. But I remember when we did our pediatrics rotation, when we were using like the Mapleson circuits, it's somewhat to do with the fact that you are ventilating your patient, but because it's not a closed circuit, you need to have enough fresh glass flow to cause elimination of the CO2. So if you had really low flows on a Mapleson circuit, your CO2 would just build, just stay there, and you can see that the end-tidal CO2 would never drop down to zero until you turn your fresh glass flows up to 4 or 6 liters per minute. And so I thought just having the two circuits there was interesting.
Yeah, I mean the Mapleson circuits are interesting in terms of the reason why you need fresh gas flow as a proportion of your minute ventilation, and it depends on whether the patient is spontaneously ventilating or mechanically ventilated on the Mapleson circuits. But in general, the theory is that when you expire as you spontaneously ventilate, the expired gas actually sits with most Mapleson circuits except the Mapleson C, they all have tubing. So most of the expired gas actually sits in the tubing itself, and you need the fresh gas flow to actually push the expired gas out. And so that's why it needs to be a function of your minute ventilation. So yeah, that's really interesting.
Yeah.
So when we think about the difference between end-tidal and arterial CO2, how would you go about thinking about that construct?
Yeah, like a lot of things in this exam, we try to categorize, and the obvious categories here are patient factors and equipment factors. And so if we were to go into patient factors, the number one thing here is alveolar dead space. So dead space definition is those alveoli that are ventilated but not perfused, and that will cause this difference between your end-tidal CO2 and your P-arterial CO2. And that's normally around 2 to 5 millimeters mercury. So your end-tidal CO2 is usually lower than your PaCO2. Okay, so as you increase your alveolar dead space, this change will increase more. And you think of all the different examples of this. And so there's respiratory and cardiac type examples that might cause these problems. For example, if you have a pulmonary embolism or air embolism, anything that blocks that pulmonary capillary, stopping the perfusion of the alveoli, that will again cause dead space. Or maybe it's not even an obstruction like pulmonary embolism, it's just hypotension or severely decreased cardiac output. And then combine this with a position issue, maybe like in a shoulder surgery. Suddenly you have less perfusion, and therefore you have more alveoli that are not being perfused, therefore increasing dead space. Then finally, things like lung disease like emphysema can also cause this as well. I think one of the other things is actually in doing anesthesia PEEP. So if you provide a lot of pressure, that will also increase the pressure within that alveolar capillary system, and that will also block off, causing decreased perfusion of that alveolus.
Well, it makes sense, doesn't it? Because with all those things you talk about, it's just the idea that with alveolar dead space and having alveoli that's ventilated but not perfused, is that, remember that CO2 is a gas that comes back from perfusion or from blood, so that you need to have perfusion to the lungs to actually get that CO2 across the alveolar capillary membrane. And if you don't have the perfusion due to all those things that you described, you're going to have less CO2 being involved, and which, as you said, would result in a reduction in your end-tidal CO2. So what's the relationship between arterial CO2 and end-tidal CO2?
Yeah, so this is best described by the Bohr equation. And if you ever go through Wes in that chapter, there's a whole derivation of it. And I've never heard of anyone actually being asked it, but it is based on some pretty obvious principles, but we won't need to go into that today. Literally look it up, follow along the logic, and it does make pretty decent sense, though it's, it'll take a long time to kind of derive.
And I understand that the Bohr equation that you have here, do you mind just quickly going through it? I think it's easy enough to describe. Yeah.
So yeah, VD over VT. So that's really the ratio of volume dead space to volume of tidal volume equals P big A CO2, so alveolar CO2, take away mixed expired pressure CO2 over P alveolar CO2. And then the Enghoff modification is saying that alveolar is very approximately equal to the arterial CO2. Therefore, it's P arterial CO2 minus pressure and mixed expired CO2 over arterial CO2.
Yeah.
And so roughly, I mean, you get different values for this, obviously, but I think the one quoted is roughly about 0.2. Is that ratio?
0.2, 0.3, yeah.
Yep. Yeah, and so obviously, if there's absolutely no difference, if you look at this equation, if there's no difference between your arterial and your end tidal PCO2, there's no alveolar dead space.
Okay, so I think that modification there, where if there's no difference between your arterial and end tidal CO2 because of no alveolar dead space, then you can actually substitute. Or can you substitute? No, you can't actually substitute it in, because if you were to use end tidal CO2 in that equation, what you would get is you wouldn't get physiological dead space. You would get alveolar dead space. That's the key thing, is that this equation uses mixed expired CO2, which, as you said, needs to be done via a Douglas bag. And if you decide to put end tidal CO2 in it, it no longer measures physiological dead space, which is both anatomical and alveolar. It just measures alveolar dead space, because remember, as you correctly described, end tidal CO2 is from your alveolar gas.
And so, just the thing to mention, it is really interesting that, you know, end tidal CO2 is such a big part of anesthetic life. You know, it's an indication that your tube is in the right spot. And it also indicates, you know, various things like, oh, you know, is bronchospasm occurring, and, you know, what is my ventilation? Am I overventilating, underventilating, all that kind of stuff. And then, have you, Stan, ever had a sudden drop in end tidal CO2?
Absolutely. And for me, that's an indicator. And the first thing that I look at is actually cardiac output. So I look at the blood pressure. And as a surrogate measure, if I don't have an arterial line in, or don't have a sort of a PaCO to measure your cardiac output, I use blood pressure as a surrogate measure of cardiac output. So what you'll often find is that when the CO2 drops, most often, not always, but most often, your blood pressure is often low. Okay, and that's often a sign for me of what has caused the patient to be vasodilated, either that I've overdosed the patient, or the patient is overtly sensitive to the induction dose that I've given, or possibly something a little bit more sinister, like anaphylaxis and other sort of rare other causes, such as any other thromboembolic causes. And then after that, once I've excluded that, that's when I start thinking about, okay, perhaps have I overventilated the patient? And so the blood pressure is fine, the cardiac output's fine, they've got a good pulse oximeter reading. And that's often a clue as well with the pleth trace. If you can get a good pleth trace, quite often you're actually getting quite adequate cardiac output. It's often when you see that, you know, that flatlining of that pulse trace with a reduction in CO2, and you're going, okay, right, probably need to give some vasopressors at this stage.
And it's really good for maybe the trainees listening to get used to this pattern recognition. So maybe first of all, you know, just remember your blood pressure is an indication of your blood, you know, of your blood pressure in the past. So that's not actually cycling regularly if you don't have an outline. So you don't really know what the, you know, perfusing pressure is of your vascular bed or your arterial system. But then there are certain other things like you mentioned. So next time you're in a case, if as soon as they institute pneumoperitoneum, or maybe you're doing an induction, or maybe, you know, you've got some rapid blood loss, the first thing I look at is, for example, as they're going in with the trocar or insufflating the abdomen, I make sure I know the end tidal CO2 and obviously the SATS trace, because that's just something you look at anyway. And over time, you'll go, oh, that did drop a bit, or that didn't drop a bit. And you'll get these indicators for something going wrong before, you know, or just as they've gone wrong, rather than, you know, waiting for a blood pressure to cycle. So I think that's really useful.
No, good point. And the pneumoperitoneum example is a really good example, because your expectation there is that when they start pneumoperitoneum, your CO2 should go up, because they're putting CO2 into the peritoneal space. And you're absolutely right in terms of, if I see the CO2 go down, that sort of indicates to me that the pneumoperitoneum has caused the patient to be hypotensive. So often with pneumoperitoneum, you're meant to, if the patient is well filled, you're actually meant to have an increase in blood pressure, given that if they've got a good contracting ventricle and they're well filled because of the increasing afterload. But if they're underfilled, it does decrease your preload, and it does exacerbate hypotension. So that's a really good point.
Yeah, it's a good one to constantly keep an eye on for, just for the practice of pattern recognition. It's a really useful one. Yeah, actually,
pattern recognition. Yeah, such a big key thing in our job. But we're trying to be systems based, aren't we now? With all your sim teaching, I think we do pattern recognition, but at the same time, we always need to have systems in place to check our skills, don't we?
Actually, I had some interesting pattern recognition. I don't know if anyone's an ALS 2 provider or ALS instructor, and you've done lots of research, maybe you've seen this, where you're doing chest compressions and you change the hand position, and that you try to make sure you're in the right position based on your end tidal CO2. And so if you're in the wrong spot, you'll have a low end tidal CO2, that's low cardiac output, and then you just move your hands a little bit and suddenly you've got high CO2s. And then this happened on a couple of occasions where I'm doing chest compressions and the CO2 jumps from 15 to 25 almost instantly. And then you're thinking, oh, well, suddenly the cardiac output has increased that much. Maybe I've got return of spontaneous circulation. And when that happens, yes, the relief is incredible. Just, yes, keeping an eye on that end tidal CO2 and seeing that jump.
It's actually one of the essential monitoring numbers that we need.
Yeah. That's good. Okay,
you've got a couple of things on equipment as well. So, how do you think about the equipment factors related to this question?
Yeah, so again, I wouldn't take too much time on the equipment side of things, except that there's so many places that this can go wrong. So just like when you're troubleshooting, a ventilator problem or a high ventilating pressure alarm system, you go from the machine to the patient. You could probably have that kind of structure if you're struggling with the memory of each of the points. So you might say, for example, equipment factors are limitations or errors in the equipment that you use. And so this could be the sampling site. So maybe there's a disconnection or a leak or something. Maybe the cable has some kind of problem, or maybe the gas sampler, that little casing has an issue and it's got a leak or a problem there. And then inside the machinery, maybe there's a calibration error. You notice that the end tidal CO2 always re-zeros, and sometimes it re-zeros at the wrong time, and you're thinking, was that the pneumoperitoneum, the cross clamp, the air embolism, or the massive blood loss that's causing that? No, it's re-zeroing. That's all right. And so there's a calibration errors. And finally, after the calibration, then the information received and converted to an electrical signal. And so maybe this signal is interpreted wrong. So if you've got a capnograph trace with some, it's irregular. Maybe there's a slope. Maybe the patient hasn't exhaled fully because it's a sloping trace. Maybe you're not actually getting the end tidal reading to adequately reflect that end tidal PCO2. Also, there's that extra thing. I think nitrous may absorb at a similar wavelength, may cause inaccuracy, but I haven't seen that in the modern machines.
Oh, that's good. I think that covers all the core essential concepts that are related to why there's a difference between end tidal and arterial CO2. Good stuff.
Nice. That's probably enough for this episode. So thanks very much for listening, everyone. Thanks for listening to Anaesthesia Coffee Break. Again, with our Patreon, it would be great to get your support. Thank you, everyone who's already supported. We're really happy to have that appreciation. So please share with anyone who might be interested, and we'll tune in again next time. Thanks very much for listening and watching.